Okay, welcome back to another podcast. As you can see, with Mr. Sam Singh, a consultant orthopedic foot and ankle surgeon, and I am in this position for a reason. We're going to be talking about the runners' foot pain. So we see lots of runners that get foot pain, and Sam's just going to go through some sort of general presentations that he sees in clinic, and obviously I am acting as the model, so hopefully he doesn't push too hard.
Excellent. So thanks, Chris. Thanks for inviting me along again. We see a lot of problems in the feet, and I think we're just going to do a bit of an overview, just to talk about what kind of things we commonly see. So we're going to break it up. We'll start with the forefoot, okay? And the forefoot generally means anywhere beyond basically here, okay? So there's a couple of things. So one of the common things that we see in runners, also in skiers, and also in ladies who wear higher heels. Yeah. You don't wear heels, do you, Chris?
Not
sure?
Not Monday to Friday.
Not Monday, only Saturday. Fine. Okay. So what we see is a Morton's neuroma, and a Morton's neuroma is an irritation. So what you're seeing there is you're getting the nerve, the interdigital nerve that runs in between the metatarsals, and its function only is to supply a bit of the sensation of the web space. It gets irritated, and it gets thickened, and it gets fibrosed. So what should be a little piece of uncooked spaghetti becomes like a little piece of fusilli in your foot. So it becomes like a little piece of pasta.
Yeah. So what takes up a lot more space. Between the bones.
The foot is tight. Because if you show me that model of the foot, you will see, so the foot is generally quite a tight space. So there's not much space between the metatarsals. And then if you imagine something's meant to be a tiny nerve that's like a string, but then becomes like a little piece of pasta between the bones, you're grinding it all the time.
And you get, what sort of symptoms would you get with the Morton's neuroma?
The lovely thing is it's a vague symptom pattern. So you might get numbness, Chris. Yeah. You might feel that there's a ruffle in your sock.
Yeah. So people say they feel like a pebble in their
shoe. And they keep taking the shoe off. Yeah. They think there must be something in my shoe, and they can't find anything. Yeah. And it's just a kind of a vagueness. Yeah. But remember, it's a nerve. So sometimes, Chris, you'll find that the pain can go up.
And the most common site is the third web space.
Third web space.
So between the third and fourth.
And the second. Right. Okay. So that's the commonest, and that's the second commonest.
Yeah.
Just to clarify, and this is very important, it is never in the first.
Never seen one.
Never seen one, and you never will.
Between the fourth and fifth?
No.
Have you seen it?
No. And if it is in the fourth and fifth, and I've treated a lot of these. I've treated several, but I've operated at least 1,000 neurons. Yeah. Okay? They here, never.
Right. So you've got to think of something else.
What happens here is when they're sore, and the reason is because this web space is much bigger. Yeah. The nerve doesn't get trapped. Okay. So you're looking at a kind of thing, and how do we know it's there? So we're suspicious of it. Yeah. So when we assess the patient with a Morton neuroma, the first thing we start with, Chris, I always start with the calf. Assess the calf, okay? Yeah. Because their calf is very tight. So Chris is here. He's struggling to sit on the couch. I can see a little bit. His hamstrings are a little bit tight. Yeah. He's actually quite tight. So if you look at the angle there, it's at best 90 degrees. And that's with the knee extended. Now, as he stretches his knee, bends his knee, he'll get a bit more bend because his gastrocnemius muscle is released. So he's not terribly tight, slightly tight calf, but not particularly bad. You look at the general loading of the foot, you'll see there's a lot more callus, which there is around here. Yeah. And then to diagnose a neuroma.
Lots of running, Sam.
Yeah, exactly. It was good. Impressive. Well done. Yeah. Okay. Now, as we squeeze there, if he has a neuroma.
So what you're doing there, Sam, is you're squeezing the forefoot.
Yeah. But the key thing is a pincer. Yeah. Okay. So, Okay. Okay. Yeah. So we're pincing. Okay. Yeah. All right. So it's a pincer grip, just like a lobster. Okay. Yeah. All right. And we're pincing the third web space. Yeah. And he should find that uncomfortable. Okay.
Yeah, it's quite sore.
All right. Yeah. So you'll find that. And then what we do is we laterally compress it. Yeah. So it's a four-way squash. Okay. Yeah. So it's like giving someone a one wedgie, and then doing them a double wedgie in the other direction. Right, okay. So it's a double wedgie.
And that would reproduce their pain.
The pain, yeah.
And you sometimes hear a click.
You sometimes hear a click. Yeah. So what we're doing, just to recap on the model, this is very important especially for physio colleagues if you listen to this. So you're using the pincer grip to squeeze the neuroma, which is just there. Yeah. Okay. It's just proximal to the metatarsal head.
So you're between the bones.
Between the bones, and then you're doing a four-way death squash. Okay. And you're if you're a small
the
one,
patient will jump,
and they love it. Now, your first reaction, Chris, you think, patients say, "Oh my God, I want to see this doctor." But remember, these patients have been wandering around. They've been wandering around for 8-9 months.
They want to know you're.
They love it. I mean, I actually go there. They go, "Is that the pen again?" I'm dragging them. You got it. That's it. That's the one. And why? Because the MRI is normal. Okay? The MRI is normal. Because we know, the real diagnosis of this has to be an ultrasound.
Yeah, I find that ultrasound, you can do an ultrasound scan whilst looking for the neuroma, and it's
X-ray is normal. X-ray is normal. But they love it. They go, that's it. You found the spot. Shake it around. I love it. Sometimes I lift their foot with it as well. You might even have a small neuroma. Good.
It's quite sore actually.
Yeah. Now, and then the second web space we check as well. So and when we examine it, we would start everywhere else so that we don't.
So if somebody had a Morton's neuroma, obviously, from a surgeon's point of view, you can take them out.
Yeah,
but what would you try before that?
So you're definitely not taking out first.
Okay?
Because an operation is an operation. So footwear, it makes a big difference. So you can look for a shoe that's got a wider toe box.
Yeah.
So what do we mean by toe box? Yeah. So if we just let me find where Chris's shoe is. So Chris has got a nice men's brogue. But you'll see one thing about brogue. So good things about it, he's got a rubber sole, which is better because it's cheaper, but also, sorry I say that, but actually it's softer, okay?
Yeah.
But this
very
is
comfy.
But this is your toe box. And actually one of the problems with the brogue is they're very stylish, but the toe box is always smaller than the brogue.
Because so if you've got a wide foot anyway,
you need a squarer toe box, okay? So you want this to be wider, okay? That's a simple thing first, okay? This other thing is you want, if it's a trainer, then you just wear a softening trainer. Okay? And a bit more cushioning on the bottom. Those are simple things you can try. And you'll find that often the winter boots cause they stop wearing the winter boots. Those things
you see it a lot in people with flat leather shoes, don't you? Or women that wear heels and pointy shoes.
Something opening out that helps. Sometimes putting a little pad under the foot can help.
Yeah, so that's called a metatarsal pad. So you can put something under that.
Yeah, you just would get them, and they're like a simple thing you buy online. You just put it there, a couple of quid, and give it a go, see if it helps.
What about toe spacers?
Toe spacers, why do they come to see me, Chris? What's the problem with the shoe? They can't fit in the shoe.
Right, and then they can't get the toe spacer.
If you put like nice lots of space, it makes a shoe tight.
Yeah, it's also it's past the problem as well, isn't it?
Past the problem. But the shoe makes a difference, okay?
Yeah.
So that's a simple thing to start.
And some calf stretching as well?
Calf stretching definitely helps because you reduce forefoot loading.
Yeah.
Okay, so that definitely helps. A bit of kind of intrinsic strengthening can help. Those are simple things you can try.
Yeah.
Okay? Using a custom insole, there's a lot of debate about that. So do we use that a lot? I am not a big fan of it, and if I speak to most of the kind of honest podiatrists, will say yes, we make a huge difference. It's very hard to get what they're doing there. Theoretically, is you're trying to lift up the metatarsal to make more space. It doesn't often work.
Sure.
Okay, and then so what does work, and I think it works, but not in everyone, and is injection. Okay.
Yeah, so we do lots of ultrasound guided steroid injections, and it's
brilliant because you confirm the diagnosis. Number one.
Yeah.
The ultrasound.
Exactly.
People forget it's not just that you're injecting.
You're
diagnosing. You're diagnosing, and they're reassured because they see this thing that no one really knows what it is. But
and you show it popping out.
Yeah, this little thing.
They do like that.
And they go, "Oh, that's your thing."
Yeah.
And then they see you put the needle next to it. They're happy that you've done it and you've injected around it.
Yeah.
But we do know the injection helps only in about half the patients.
I'd agree, and depends on the size. Sometimes you see them and they're really quite big.
And I know me and you in the past, you said to me, Sam, just take it out. Oh, it's been going on for 4 years. The nerve is so scarred that it's not going to get better. I agree with you. Okay? But the steroid is worth trying. And patients say, well, why would I try something when it only
and for a small neuroma, I think they can be fine.
And it only works in half the patients because it's so easy. It takes about 1 second once it's done, and they're on the road to
interestingly, in one study, they found that 50% of the cohort, the population that they studied, had a neuroma but didn't know about it.
Absolutely.
So people are walking around without them, but then they change their shoe or they start running.
Symptomatic.
They walk a bit further and they become symptomatic.
I'm so glad you said that, Chris, because this is important. So people's first reaction is, well, why would I mask the problem? Because you get a lot of that.
Well, why would you not just take it out?
Because you do cortisone injections. People say, why would you mask the problem? Because actually, it's not a cancer. You don't need to eradicate it. And you don't need to cure it. You just need to palliate the symptoms. I don't need to treat your neuroma. It's not essential to treat it. Having it in your foot is not damaging your foot. It's only if it hurts. And then if it doesn't work, the injection, number one is you can do a couple, but I wouldn't keep doing them.
No, absolutely.
Okay, and the reason is because you need the fat. One of the key things, if you look at Chris's foot, which is not that well padded actually, but he's got a bit of callus there, but he's got that fat there, and that fat is important. And if you keep doing the steroid injections, it can erode the fat. So,
absolutely.
So hence we take it out.
Couple of injections.
Surgery's got a bad press a little bit online, okay? Because there are whole Facebook groups, okay?
Oh, really?
Yeah. So
against
I had
surgery?
a great patient yesterday. She goes to me, Mr. Singh, you really reassured me. I'm going to come off the Facebook group now about why you shouldn't have an operation on Morton's neuroma.
Really?
Yeah. But then I said to her, well, look, stop, stay on it and say that actually you had the surgery and you did better rather than just leaving the group as it is.
Gosh.
But actually surgery does well.
Yeah.
But surgery, Chris, is often done badly.
Right.
And this is a problem. Okay. So the one risk we worry about in the operation. So patients, there's a lot about numbness. Okay.
Yeah.
I've done it for years, this operation.
Yeah.
Okay. And the numbness does not bother a patient ever. It's the pain.
Yeah.
But remember, patients and general, we all think of numbness as being that burning pain. But it isn't. Numbness just means, to me, medical numbness means if I touch here, you can say I can't feel it.
Yeah, yeah.
But you can feel the rest of your foot, just here you don't feel it. It doesn't bother you too much, okay? That's medical numbness, okay? Now, risks of surgery. Surgery has got risks.
Yeah.
Every surgery. And the main risk that we worry about is a stump neuroma, okay? So if you cut the nerve, a new nerve can regrow.
Yeah.
Okay? We'll worry about that.
How often?
It's so histologically, if you look on a microscope, every time you cut a nerve, it regrows a little bit.
Yeah,
okay?
Sure.
So what is the key thing? And this is how you get a good result. And I know.
Yeah.
So I know we get good results.
Yeah.
And the reason we get good results is because we take a lot of the normal nerve out.
Right.
So that if you're going to form a stump neuroma, it's deep inside your arch. And what do we know about your arch is that you don't walk on the arch.
Right. Okay.
Okay. And that's the key thing here.
Yeah.
Okay. So you don't walk on the arch. Now, so further up, so we leave it further up. So that's the Morton's neuroma.
Yeah.
So the surgery is successful.
Yeah.
Do we do the first line? No. How long should you have symptoms? Probably at least 6 to 9 months. I wouldn't do less than that. Okay.
Yeah.
Ideally even a year. Okay.
Yeah.
If it's not bugging them, we don't need to treat it. It does not need to be eradicated.
Sure.
It's not a cancer.
No.
Okay.
Yeah.
But if it hurts, we fix it.
Yeah.
Then we talk about the big toe for a bit.
Yeah.
So big toe arthritis. Okay.
Very common.
Very common. And it's much common in younger patients.
Yeah.
It's actually the arthritis of young people.
Yeah.
Because you don't really get hip arthritis in young patients.
No.
You don't really get knee arthritis.
Big toe. Why is that?
Big toe, because we think it's linked to trauma. And the trauma can be very occult. Okay.
Right.
So what happens is they form a little area of cartilage damage, osteochondral defect.
Yeah.
And that is what
Starts
triggers
the process.
And how does it happen? It happens, they might just have kicked the box. Not even, the kind of thing where you've kicked a step and you just shake it off.
Yeah.
You don't even remember it's a life event.
Right, okay. But that triggers something.
That triggers it a few years down the line, starts to trigger the process. So it's often trauma related.
Yeah. But you need to rule out gout.
Gout.
We've seen quite a few of those recently.
So how does gout look, Chris?
Yeah, it looks...
Have you had it?
No, but I don't
know the red wine's not
No.
No, good.
The key difference is it's really swollen and really red.
Absolutely.
And they're in agony.
Yeah, it looks like it's swollen.
It's a sausage.
And they put like a bed sheet on it and it hurts.
Yeah.
They put the shoe on it hurts. They're walking around barefoot because it hurts so much.
Yeah.
And it just touching it can be sore.
Yeah.
And it has it doesn't go on for 3 months. No. Gout is bad for 5-6 days and it starts to come down. And there is an increased incidence of gout. So we must remember the incidence has shot up massively, which is such a paradoxical thing because people are being more healthy now.
Wow. We talk about being more healthy now. I'm not sure if we actually are.
But
if you get gout, is it colchicine that you get given?
You might be given colchicine. You start with NSAIDs,
right,
and then obviously if you keep getting gout, then you talk about colchicine, albumin, all that kind of thing. You start with simple NSAIDs, okay? And if you think it is, then you can have a blood test, which is on and off reliable. Because sometimes when you have an acute flare, the blood test might actually be...
We can see them on ultrasound really
you
nicely.
You see the little crystals. Little shiny crystals, absolutely.
And also, but it's important that it's normally lifestyle changes, isn't it? It's about what you're eating, what you're drinking.
But it is quite nice to nail the diagnosis.
Yeah.
So if you're saying quite nicely you've seen the crystals on ultrasound, actually it's quite a nice thing to do. It's nice to know the diagnosis because of the fact that you might go into preventative medicine medication. Sure. So it's nice to have the diagnosis that way. But it's a big red hot toe, okay? But the arthritis is diagnosed more easily by dorsal spurs.
Yeah.
So osteophytes form when you have a joint that's arthritic, Chris. We get these bones that grow on the top.
Extra bits of bone,
and so in the big toe, the nice thing is we can feel them. Because they're just on the top. So what happens when you have an arthritic toe is you as you bend the toe, you catch and snag the osteophytes.
Yeah.
But my diagnostic tool for a big toe arthritis is not pain on grinding the joint.
Yeah.
Not pain on going on the top. But it's the only time when you pull the toe down, they get pain.
Yeah.
And because
compressing,
you're pulling the nerve and the tendon over the bump, okay?
Yeah.
You see if Chris has you've got a nice healthy toe there.
Not too bad.
No, it's pretty good toe.
Not too bad.
A little bump there, but it's not an arthritic bump. Okay? And obviously a bunion which sticks out there.
Yeah.
We love bunions, Chris, we do.
Yeah.
We love listening to them. But we don't need to treat bunions if it doesn't hurt.
If it doesn't hurt, you don't need treatment. Some people do think cosmetically, but I think you're in.
So if it doesn't hurt, don't treat it. But if it hurts, singing songs to it, it's not going to make a difference.
The other thing,
okay. What about wearing an insole? I love that one.
Yeah.
Hey, I've got an insole. Let me just give you the reason the patient came to see me, Chris, is because their bunion, which is big red, looks like a hooter, doesn't fit into the shoe.
Yeah.
Okay. But what I love is when they can't fit it, and then they go and they see our friendly podiatrist around the road, who gives them something that looks like my iPhone to put inside the shoe.
So
what we need in the shoe is space.
Yeah, even less space.
Okay, there's even less space. So the problem is putting things in your shoe works if you don't need the space.
Yeah.
But if you need the space for your bunion, and that's the problem, it's a space issue, isn't it?
Yeah. And actually, there was a study once that showed that 90% of us wear shoes that are too small.
Always.
And I remember a podiatrist telling me the test to do is when you stand up, you should have like a thumb width to the end of your shoe. And I think particularly with runners, sometimes they're a little bit tight.
Yeah, absolutely. So you have learned that from here. So let's try that, Chris, again. It's a good point. So this is Chris's shoe. Yeah. Look, he's got a nice thumbs width.
Yeah.
Well done.
Thank you.
You did listen.
But you do it in standing. When your foot splays out. Yeah.
Because it does splay out.
Yeah.
And therefore you'll find often, and therefore even when we image a bunion, we actually x-ray them standing.
Yeah.
Because that's when their foot looks like what it does.
So what if you've got big toe arthritis, I assume it's similar to the Morton in terms of wearing the right shoes.
Yeah, and so I would vary the shoes. I would try oddly. You're gonna think, God, this doctor's he's not very decisive, is he? I actually say to my patients, try 3 types of shoe.
Right.
Okay. Try a very soft shoe, like a knitted fly knit trainer.
Yeah.
Because that may be that you get pain from the rubbing.
Yeah.
Some patients do. I say try a very soft bendy, so soft that actually nothing troubling.
Yeah.
Or the opposite, do a very stiff-soled shoe.
So you don't bend your
shoe is relatively stiff, so you're not bending the toe as much.
Yeah.
So therefore, you're not impaling the osteophyte. Okay.
Yeah.
And then the third one is obviously the rocker sole.
Yeah. What do you think of them?
Which is worth trying.
So these are the soles that basically rock heel to toe.
Yeah, like wibble wobble. You keep rolling.
The Hocker shoes.
The Hocker has a bit of
one now.
And you know why, don't you? Which I didn't know, because Hocker is made by the guy who used to make MBT.
Oh right, I didn't know that.
I didn't know that. That's why
MBT were always
they're fashionable.
They don't seem to be around anymore, do
they? For some reason. No. I think they got some lawsuits about.
Yeah.
Maybe something. But
so
you're rocking as you roll. Okay.
Yeah.
So you don't end up bending the toe at all.
Right. Yeah.
So is it good? Well, they're just protecting it. It's an arthritic joint. There's no great plan B. If it doesn't, the cortisone injections help.
Yeah, the injections can help, and we do a few different types of injections, but not always.
Not always.
But when people are in a lot of pain, it can certainly help.
And it nearly always gives them some relief.
Some relief, yeah.
But if they've got a big spur on the top,
then
the commonest thing we do is just knock the spurs off.
Yeah.
Okay, and colectomy.
Yeah.
So you go in and you basically do a little incision, you just hoof off all the spurs, remove it, and then the toe bends freely, stops pinching. Yeah. Weirdly, you get away with it. And my own theory, after doing this for many years, is I think the metatarsal head is quite small.
Right.
And therefore, you get away with it.
Right, okay.
Other joints, I couldn't do a colectomy of your knee.
No.
Expect that to cure the arthritis. Or your hip and cure the arthritis.
Yeah.
It doesn't. But I think with the big toe, because the actual joint's so small, a large part of the pain in an arthritic big toe is actually the
tissues and the osteophytes. Okay, so we're talking about runners. So one thing we can't avoid is the potential of a stress fracture.
Absolutely.
So we see lots of stress fractures in long distance runners. The first thing that springs to mind is that an X-ray doesn't always show a stress fracture. So you've got to get the right imaging. But essentially, do you want to just go through what?
Absolutely. So firstly, Chris, do professional athletes get stress fractures?
They do, yeah.
Do they?
They do, yeah. I worked at British Athletics, and they definitely got stress fractures.
Or is it more the person who suddenly wraps things
But
up?
It's less likely than in recreational.
People think a stress fracture is a sportsman's injury.
No,
it's not, because it's the untrained person ramping. It's the person doing couch to 5K and suddenly thinking, I did this before lockdown a year and a half ago. I'm just going to start a 3K. That's the person who gets a stress fracture. Or the person suddenly a bit behind schedule. Because nowadays we see, I had a bit of COVID, I couldn't really go out, but I'm booked to do a half marathon. I'll just start on week 4. I'll just start now.
So too much too soon.
Too much too soon. Okay. So in the history, some things we should ask about, and it's important to, we always ask, you ask the same questions. Dietary deficiencies. if you have I look at the patients, they're very thin.
Yeah.
I worry, are they missing things?
Yeah.
Have they got a diet that's missing large components? Are they, for example, have they got a vegan diet? They're missing large, or they've got big exclusions in what they eat. In females, are their periods regular? They're irregular, that kind of thing. You start thinking about maybe about thyroid problems, other, the general kind of screening questions. And have you had it before? Yeah. Because what you don't want to find out is this is their third stress fracture. And me and you have just been treating them without thinking about that. So we have to be thinking that. But the giveaway sign for a metatarsal stress fracture, there is one giveaway sign, and it's swollen along the metatarsal. Yeah. And people's ankles and feet swell. Yeah. Okay. But the only condition that gives you swelling in one linear direction is a stress fracture. Yeah. So you'll have this will be fine. This will be fine. Yeah. And then just there'll be a third metatarsal stress fracture. For example, when I look at your foot, I won't see the tendons. Yeah. And I press there, there'll be a bit of boggy swelling. Yeah. And as you press there, then
they normally jump off the bed, don't they, when you squash it?
And that's a stress fracture. So the trick about that is,
and the other thing is with a stress fracture in the history is it will be that you go for a run, it hurts a bit, but it's fine. Yeah. And then it builds, it's that crescendo pain, isn't it? And it gets worse and worse. Absolutely. And the thing is with this is you have to stop. You have to stop running. You have to rest it.
And you have to rest it. Yeah. And either you just go, if it's not too sore, then you just go in the trainer for a bit and just ease how much you do. Don't sit there counting your steps every day. Yeah. You didn't get to 10,000. Just slow down.
You don't have to go into a boot.
It's an injury. You don't have to go into a boot. No. But a boot does help. If you're sore, then even if you pick one up online, just pick a cheap boot up. It doesn't need to be a flash one. Yeah. A cheap boot, just use it for a couple of weeks. So you're not living. Walking boot, and automatically wearing a walking boot slows you down. Or automatically it's a sign to others that you can't really go out that night. You can't go for a walk with them. That kind of thing. It just slows you down.
Gets your seat on the tube.
And they heal better. And the answer is that once they feel confident, they can start walking again. Sometimes I'll even treat them without even imaging them. Right, if they come in and they give me the story and they test, it's very sore, fine, just go to boot, done. And then give it 3 weeks, take it off, it'll be fine. So with something, and ultrasound's quite good at picking up.
Yeah, it can be very good. See
the little cracks.
And obviously MRI is probably gold standard.
Is the gold standard. X-ray is unreliable.
Yeah, I'd agree with that.
So if they say they had an X-ray in A&E, so at 10,
it doesn't rule it out.
10 days you start to see them.
Yeah.
Because you see the callus. You won't see the fracture, but you see the callus here. You might be,
so if you've had an X-ray, so for people listening, if you've got pain and you've had an X-ray within that first 2 weeks of pain, then the X-ray is unreliable, isn't it? Yeah. Okay. So you can't rule it out.
Yeah, absolutely. And then just one other topic, just what we got. So runners get quite a lot of pain here. Chris, you like this one. I mean, you love this one. Cuboid syndrome. Okay. Yeah. So the fifth metatarsal is there, and just there is a cuboid bone.
Cuboid,
and this big tendon comes down here and does a right turn bend to the other side of your foot, and there runners get inflammation.
Yeah. Quite tricky to get better.
Difficult
to diagnose.
Yeah. So if someone's running and they come and say my foot hurts on the side, I'm always thinking that's cuboid syndrome. And it could be like a little piece of bone in the tendon called an extra bone.
What's that?
Osperonine. Okay, that makes you think of that beer that makes you thirsty. Yeah. Good. But it could also be just something like a cuboid stress fracture.
And you just diagnose that mainly through palpation.
And then sometimes it's propping up the foot. Activity modification can help it. Yeah. Sometimes, we use a bit of cortisone if it's inflamed. No real surgical treatment for that. Okay.
And then just as a last one, which is probably one of the most common, is plantar fasciitis in runners.
Okay, so plantar fasciitis. What's the chance of me and you getting plantar fasciitis, Chris?
I probably need to run a bit more, but
1 in 2.
1 in 2.
So one of either me or you can have once in a lifetime.
Wow,
okay,
that's
horrible. So the story gives it away.
Yeah.
The story, and if they don't have the story, I start thinking my diagnosis might be wrong.
Yeah.
Okay.
Well, you have to rule out a stress fracture of the calcaneum, heel bone.
Exactly. So stress fracture calcaneum is typically here.
Yeah.
So if you squeeze, so if you squeeze the heel, if we squeeze there, that's your calcaneal stress fracture. Plantar fasciitis is at the bottom. Yeah. The plantar fascia is a ligament that starts here. And we know it spans into the foot, but where it starts there is where they get the pain. Yeah. And that's what we don't want. So we don't want if it's sore there, that's plantar fascia.
Do you want to show that on me?
Yeah, excellent. So I'm just going to, so if you see Chris, so firstly, what is the plantar fascia? As I bend his toe.
Tickle, Sam.
Tickle, he's got this thing. He's got this ligament here. As we bend his toe, we can see this ligament, which is the plantar fascia. It comes out here, it starts here, and it comes out to his foot, and it just fans across everywhere. But you feel like a thick rubber band there. Now, some patients, a small proportion, do get pain there. If they get that, it's nearly always due to the calf being tight.
Yeah.
And some get pain. Most people have pain exactly here. Okay, so aggressive leg. That's typical place where people get the pain, okay? Just there. So start up pain, first thing in the morning, get out of bed, get up from their desk, out of bed.
Yeah.
I'm seeing more of it, by the way. Working from home.
I'm seeing a lot of it.
Working from home. You know, can I just tell you what I'm noticing? What happened working from home? Oh yeah, they do an hour's running or half an hour's running a day, and then they do nothing for the whole 23 hours, and then they do an hour's running. It's like a binary system, you know. It's
and plantar fasciitis classic symptoms, not always, is that they get it worse in the morning. You sit for an hour, you get up, it's painful, and then it can go.
Yeah, but not always goes, and sometimes till the end of the day they get sorted.
Yeah.
But and then the thing is stretching is the key thing, Christian. If they stretch the calf, that's the main
and we concentrate quite a lot on strengthening as well, and strengthening the foot and the intrinsics.
And conservative treatment is the way forward.
There's generally, people used to do surgery.
No, God, no, surgery is terrible for plantar fasciitis.
Right, okay, that's what my impression was.
One or two my whole life. Because it just doesn't do well.
Yeah.
Occasionally, if the calf is very, very tight, you might release it. Yeah. But even that we avoid.
And at the clinic, we use shockwave.
Shockwave is very effective.
Which can be really useful. It's a nice adjunct to have.
It is, and it's a very simple thing. Yeah. It hurts like hell, but it's good. And it gets in the spot. So what you're doing there is you're tricking the body into thinking that this is chronic inflammation. Yeah. And chronic inflammation is bad inflammation. All it does in life is hurt. Yeah. Acute inflammation is painful. Yeah. And it can be bad, but it can be good because that's how we heal broken bones. That's how we heal damaged tendons. So we're switching the chronic inflammation for an acute response. So your body's it's a very kind of holistic thing. You're using your own body.
Well, it's non-invasive, isn't it, as well, shockwave? And we often will advise people to use heel pads.
Just to take pressure
off. But I don't like the silicone ones, the ones that move around. I like a nice solid to take a bit of pressure off.
To take a bit of pressure. So you're lifting them up. That's also resting their calf a bit because they've got a bit of a ramp. Because remember, they'll often be wearing flat shoes. Yeah. And flat shoes are terrible. If you look at shoes.
Well, the classic is somebody goes on holiday, walks on the beach, or walks in flip flops, and they come back with plantar fasciitis.
What is it with the British going on holiday where they end up wearing shoes the whole year, except for the week when they have to walk by the pool? They just decide they wander around town and then barefoot. They get plantar fasciitis. Yeah. I'll tell you, I've once had plantar fasciitis. You know where? Water park.
Oh, really?
You have to take your shoes off. God, climbing to the top of a tower barefoot. By the end of it, you are dying. Okay.
And you do have very flat feet.
And I do have flat feet.
Found out on the previous podcast.
Exactly. So I have flat feet. So cool. I will. That's one place you do it. So stretching the calf, shockwave helps. And as you know, sometimes it doesn't land. A cortisone injection is effective. Not straight away. So don't do it straight away. Give it 3 months.
Battery change.
Cool. We're in.
Yeah, I'm gonna have to shoot off in a minute. So
we're on the last.
Should we just go from where did we get to?
Go from you started summarizing the effective treatments for plantar fasciitis.
So you just said so. Sum it up like heel raise, do this, do that, shockwave. Yeah. You can always do an injection.
Same image back. And away you go.
So just to recap the treatment of plantar fasciitis. Number one is, as a clinician, we don't need to intervene until the patient's been symptoms for a while. Yeah. The most important thing is this is not arthritis. It does get better. Yeah. And I have patients very frustrated coming to me at 3 months, 6 months saying, "Why it's not going away? Will I be left with this for the rest of my life?" Yeah. Very rarely you are. Nearly everyone gets better. Yeah. And one day it just disappears. Now, how can you help it disappear? So initially, avoid flat shoes. Yeah. Wear shoes with a bit of a heel, with more cushioning in the heel, and sometimes putting a silicone heel lift and a thick one, the thickest one you can buy.
Quite dense
tissue. Yeah, rather than one that's just wobbling around in the shoe. Exactly. A really proper one, okay. And one I even like the ones that go over the back as well, okay, which stop the thing from sliding around in the shoe. Silicone heel cup, stretching, because the tight calf often leads to the tight plantar fascia.
I find strengthening as well.
Strengthening, so you're doing the single heel raises. But remember, if they strengthen, they've got to stretch. Yeah. Otherwise, they're just going to have a tight contracted muscle. Yeah. It's a strong contracted muscle, so they've got to do both. Yeah. Sometimes even the frozen Coke bottle. Yeah. It's quite a nice one because it's frozen.
Tin of beans. Take the wrapping off the tin, put it in the freezer, and then.
And it's just nice cold, a bit of cold. Yeah. And these simple things. And you're buying time. Yeah. Because we know the natural history is most patients get better.
Yeah. We also use shockwave, as we said, and on occasion injections. If people are really struggling, it's affecting their quality of life. They can't get to work.
If they're getting to the 3 month mark, then I'm thinking shockwave, I'd start about 6 weeks is fine. Yeah. 3 months if they're not getting better than steroid injection, I think
Sure.
is a reasonable option. Okay, success rates of both are roughly the same.
Okay.
And remember, you're managing the symptoms because
Yeah.
it's a naturally limiting condition.
Yeah, self-limiting.
Self-limiting.
Cool. And that's
Brilliant.
what people often need to hear, isn't it? That
Yeah,
this
it
will
gets
get
better. It gets better. It looks like it never will.
Yeah.
When you wake up every morning in misery,
Yeah.
and the simple thing is what the misery in the morning is stretch before you get out of bed.
Yeah.
So hit the snooze button
Yeah.
and then just do an against. I just say do this. Pull your foot up as much as you can. Just keep it
Yeah.
like that for a few seconds
Yeah.
before you get down. And don't go barefoot to the toilet. Because what do? We get out of bed and we go into the stone floor, which is cold, barefoot.
Yeah.
And then the rest of the day we're wearing shoes.
Yeah. Some people also use those Strasbourg socks,
The Strasbourg
the night
keeps you stretched up
splints.
at night. Yeah.
Have you found people have
They're
had them?
okay, but patients don't generally tolerate it.
Yeah, I think it's going a bit out of favour.
Yeah, it's a
isn't it?
little bit
very hit and
and
miss.
It can, and if you don't have to wear it the whole night, remember.
No.
So if you like the kind of person who wakes up during the night, you can put it on
Take
then.
it off.
Or if you wake up and go to the bathroom and put
Yeah.
it on when you come back to
Yeah.
bed for that last couple of hours.
Cool. Okay, well, thanks very much, Sam.
Cheers.
That's really good.
It was a pleasure, Chris.
So if you are a runner that's getting forefoot pain or you've got any questions, then I'm sure myself and Sam are very happy to answer any questions. I think the important thing is to get the right diagnosis and particularly stress fractures, because you don't want to be getting the wrong diagnosis and running on a stress
Absolutely.
fracture, because you could
Absolutely.
cause further damage with that, couldn't you? Brilliant. Thanks, Sam.
Cheers.